Hi, my name is Dr. Doug Steenblock. I'm a psychiatrist at the Iowa Veterans Home in Marshalltown, Iowa. We've brought this presentation to you as a form of education for all nursing home employees. This is something that we've done for our own employees, and it is geared for people who work at any level in the facility. Hopefully you'll find it beneficial, but I suspect there may be some in the audience who probably feel that it might be a little too basic, and if that's the case, I will apologize up front for that. First, I'd like to talk a little bit about the Iowa Veterans Home. It's a very unique facility located in Marshalltown, Iowa. It is the biggest long-term care facility in Iowa and one of the biggest veterans homes in the country. We usually have a census of about 500 beds, and we have beds in nursing, memory care, and residential care. It is open for veterans and for spouses, and we offer complete on-site medical and mental health services. As Chief of Mental Health Services here, I oversee 2 psychologists, a physician's assistant, and a mental health nurse. I'd like to briefly summarize my background. As I mentioned, I am the supervisor of mental health services at the Iowa Veterans Home. In that role, I not only supervise other clinicians, but I also provide direct psychiatric care. I'm a consultant at our local community mental health center, and in that role, I see a number of patients in the community at private nursing homes. I serve as an adjunct clinical faculty member at the University of Iowa and at Des Moines University, and in that role I work with a number of different types of trainees, including fellows, residents, medical students, PA students, etc. My primary clinical interests include the delivery of mental health care in long-term care facilities, geriatric psychiatry, and treatment of chronic mental illness. Let's talk about statistics. Here's one statistic that I think is sort of central to our discussion. 56% of nursing home residents in Iowa and nationally have mental illness, and this comes from the government's MDS data. And that number does not include dementia, so I think if you put that into the mix, you're probably looking at a number that approaches 100% in my opinion. I'm going to talk about some common disorders today, and again, if you have a background in mental health, this is where you might find it fairly basic or maybe not as in-depth as you would like. But these are the disorders that we will touch on, and certainly this is not intended to be comprehensive. There are many other mental health disorders that we won't talk about today, but again, these are some of the more commonly encountered disorders in long-term care facilities. An adjustment disorder is simply, like it sounds, an adjustment to a stressor or to a loss, to a problematic situation. By definition, adjustment disorders are typically short-term. They typically resolve once the stressor or the problem at hand resolves. So an adjustment disorder can be accompanied by anxiety, by depression, disturbances of emotion, conduct disturbances, etc. The primary form of treatment for an adjustment disorder would be counseling and typically not medication. Now, in more extreme cases, medication might be considered, but typically it is not necessary. Next, I'd like to talk about anxiety disorders. Now, the general concept of anxiety is kind of interesting. If you think about it, anxiety really does have a positive side to it. Anxiety can keep us more focused. It can keep us safe sometimes. But in many cases, when you're looking at anxiety disorders, you're looking at anxiety that has sort of run amok, that is at pathological levels. And it's typically because we aren't getting something that we need, or we're afraid that we won't get something that we need in the future. And when you look at different types of anxiety disorders, they really are quite variable in many ways. Generalized anxiety disorder, as the name implies, is much more generalized and ongoing, and it doesn't really come in episodes so much, but certainly when people are under stress, when problems arise, generalized anxiety can get much worse. So this is a sense of tension, sense of anxiety, worry, and so on that is kind of relentless for a lot of people. And one way I think that you can identify someone with generalized anxiety disorder is simply ask the person, are you a worrier? And a lot of people who have generalized anxiety will say emphatically, yes, I worry about everything. Or their families will say, yes, she's always been a worrier. So that is definitely a clue. Then we have panic disorder or panic attacks. Now, one thing I like to say about panic attacks is that those can occur within the context of many other disorders, including phobias, OCD, or PTSD. Panic attacks are very physiologic. They are the patient has a great deal of physical symptomology. Their hearts are racing. They may have chest pain. They may be short of breath, tremulous, sweating, upset stomach, and so on. So they are, physically very uncomfortable. Panic attacks can sometimes occur for really no reason. But as I said earlier, generally there is some sort of trigger, such as a phobia. And phobias are one of the more common types of anxiety disorders. In fact, it's one of the more common types of psychiatric disorders in general. But not that many people go to a mental health provider to get treatment for a phobia. A lot of people just live with their phobias. So this can be a fear of many things, of needles, of heights, of all sorts of different things, snakes, you name it. And so the phobia, when there's exposure to the feared stimulus, then the person may have a panic attack. There's also such a thing as agoraphobia, where people are frightened to leave their home, and they get very anxious if they get in public places or if they get out on the highway in a car and that sort of thing. Now, obsessive compulsive disorder, I think, is misunderstood by a lot of people. Some people will say, well, I'm OCD because I rearrange my desk constantly, or I want everything in order. And that's not necessarily accurate. That might be more consistent with an obsessive compulsive personality, which we'll talk about later. But true obsessive compulsive disorder really is a pretty serious disorder. In this situation, people are having very strong, intrusive thoughts, which we would call obsessions, that in many cases are even irrational, and they sort of drive the person to engage in compulsive behavior. So one example might be germs. People who have constant obsessions about getting infected, about bacteria, about germs, and so on, and they may walk around all day long with these horrible intrusive thoughts in their mind that they cannot ignore. This may cause them to wash their hands compulsively and excessively, even all day long, repeatedly. There are other types of OCD as well. You may see people who have obsessive concerns about safety and want to check door locks constantly, or they want to check the burner on the stove constantly. There may be people who count quite a bit, or who are very obsessive about symmetry and those sort of things. Now, PTSD, I think a lot of people have heard of, post-traumatic stress disorder, and a lot of times we associate this with combat, but it can occur in many different situations. It can occur even from being in an ICU at a hospital. So you could have a nursing home resident who went to the hospital, became very ill, got intubated, got put in an ICU, and later they may have classic symptoms of PTSD. They may have flashbacks and nightmares and, easily startled, mood changes, etc. In terms of treatment, there are many different options, and it depends in some situations on what disorder that you're treating, obviously. But generally speaking, antidepressants can be very beneficial for a lot of different types of anxiety disorders. Occasionally, we will prescribe anti-anxiety medication, such as benzodiazepines, that are also known as tranquilizers or sedative hypnotics. And we don't typically like to prescribe those medications long term. They aren't ideal for older people for a variety of reasons. They may dull the cognition of an older patient. They may make them less steady on their feet and lead to an increased number of falls. They can be habit forming. So as a sort of an immediate stopgap measure, sometimes benzodiazepines like lorazepam or alprazolam and so on can be beneficial, but again, I don't think it should be the mainstay of treatment for most people. Some people just simply need sleep medication. Trazodone, for example, is one that we use very commonly. And counseling. Now, counseling is a very important part of treatment for people who have anxiety disorders, but there are some obvious limitations in long-term care settings. For one thing, you may not have access to therapy services in your home, in your facility. Although that is changing to some extent, especially with telemedicine and so on, which is now more readily available. Another roadblock, however, might be the resident. In some cases, you may encounter residents who are too cognitively impaired to benefit from counseling. They may have hearing impairments that are barriers, and in some cases, they just may not be motivated. They may not want counseling or may not want to engage and do the work, which is true of patients of many different ages. Let's talk about depressive disorders. So most of the time when people say, I was diagnosed with depression, what they really mean is major depression. That's one of the more common types of depressive disorder. But there's also such a thing as persistent depressive disorder. It used to be called dysthymia, and it's more of a chronic, long-term type of depressive disorder. It may last for many years. And there are others as well, but I think those are two of the more common types of depressive disorders that we would encounter in long-term care. The treatment would be obviously antidepressants and counseling. Now, again, this is a case where counseling can be very helpful. In fact, many studies have shown that counseling alone can be just as beneficial as antidepressant treatment alone. But I think the combination of antidepressants and counseling is probably the best approach for most people. Again, though, in long-term care, you may encounter some of those same barriers where you may not have counseling services at your facility. You may have people who have hearing loss or a lack of motivation or cognitive difficulties. So it doesn't always work out as well as we would like. And sometimes we do focus more on treating depression with medication than we would like, but it may be our only option. Now, in more severe cases of major depression, we still refer people sometimes for electroconvulsive therapy. It's also been called shock treatments or shock therapy. And I know some of you may think, well, I had no idea that they still did that, or I thought that was illegal or unethical. And it's not. It's actually a very safe and effective treatment that is still performed widely by some of our best medical centers. I know we have referred many people from our facility to University of Iowa, for example. I've had patients who had this treatment at Mayo Clinic in Minnesota. So there are some excellent medical centers who do this, I think, very skillfully. It's not for everybody. It's only reserved for certain types of patients, usually more severely affected patients. Now, here's a little mnemonic that you can use if you're trying to determine whether your resident, your patient, has major depressive disorder. It's called SIGI CAPS, very common. Every medical student has learned it, I think. But we basically can look at some of the key features of major depression by using this mnemonic. Sleep. Most of the people who have major depression are not sleeping as much as they would normally. Now, there are some types of major depression where people actually sleep more than they normally would. People who are depressed often lose interest in pleasurable activities. They sometimes experience a sense of guilt or low self-worth, low self-esteem. They have less energy in many cases. Sometimes, especially in older people, you can see cognitive or intellectual changes. So people can start becoming more forgetful, having more difficulty concentrating. Their thought processes can slow down somewhat. So in some cases, even it may appear that they have dementia, when in fact it may be depression. So that's an important distinction to make, I think. A lot of people who are depressed have lower appetite. Some people binge eat, though. Some people have higher appetite when they feel depressed. Psychomotor retardation is not uncommon, meaning that people have less activity than they normally would. And then some people do have suicidal thoughts, which we'll talk about a little later. Now, bipolar disorder, also known as manic depression, is a disorder where you might see the major depressive episodes on one hand, but you also may see manic or hypomanic episodes. So bipolar 1 is a more severe version, and in that disorder you will see the major depressive episodes and the more severe manic episodes. And when I say mania, I'm talking about a high mood where people get very activated. Their thoughts race, they may talk excessively, they may stay up all night, they may engage in a lot of pointless activity like cleaning furiously or just doing things that don't really make sense. And so they're in a high state of activation. In bipolar 2 disorder, you still see those major depressive episodes, but the mania is less severe. It's known as hypomania. So that activation isn't quite as extreme. We treat bipolar disorder with mood stabilizers, medications like lithium or Depakote, for example. We may also, in some cases, use antipsychotics to treat bipolar disorder. Counseling can be used, although usually the focus is on accepting the illness and managing the illness and so on. And then in extreme cases, in more severe cases, we would consider ECT. Schizophrenia is something that we see very commonly in our facility. We have a number of schizophrenic residents, and most of them are, I would say, on the more severe end of the spectrum, people who have not done very well with outpatient treatment. Schizophrenia is a lifelong progressive brain disease, and it's characterized by a number of different features. Most of the patients have positive symptoms of psychosis, which would include hallucinations, delusions, and so on. The hallucinations are often auditory. In other words, they may hear voices or noises, but in some cases they may have visual as well. And certainly we've seen people who have olfactory hallucinations. They can smell things that aren't really there, and so on. Delusions, especially paranoid delusions, are certainly a common feature of schizophrenia. A lot of schizophrenics also have marked disorganization of their speech and their behavior. We'll talk more about that later as we move on. And then they have negative symptoms in many cases. And the way I think of negative symptoms are things that are missing. They don't really have much enjoyment in life. They don't really have an expression on their face. They're very flat. They don't take any initiative. So with a schizophrenic resident, if you let them lay on their bed and you don't try to engage them at all, they may just be happy to lay on that bed all day long and do nothing, to not watch TV, not read, because again, there's something missing there that causes them not to seek out initiatives on their own. They can be very odd. They can even be sort of autistic in some ways, where they don't do very well in social situations. They don't read the cues that a lot of us read when we interact with people. And so very socially inept in many ways. The treatment for schizophrenia would include antipsychotic medication, which is fairly effective in reducing the positive psychotic symptoms like hallucinations, delusions, the disorganization, but it unfortunately is not very effective in most cases in treating those negative symptoms. Counseling can be of some benefit, especially in helping the person to accept their illness and to manage it appropriately. And again, in much more severe, unusual cases, we may refer for ECT. Schizoaffective disorder is a condition where you see some elements of schizophrenia, but also some elements of depression and or mania. So in this case, depending on the presentation, we may use antipsychotics, antidepressants, mood stabilizers, counseling, or ECT. So it may have, again, some elements of a mood disorder, some elements of schizophrenia. We'll shift gears a little bit now and talk about neurocognitive disorders. I've tried to simplify this by breaking it down basically into two categories: dementia, which would be long-term confusion, and delirium, which would be more temporary. Dementia, which is now known as major neurocognitive disorder, is becoming increasingly prevalent in our society and really throughout the world. And this is probably due to many factors. People are living longer, and dementia tends to be more prevalent as we get older. In fact, by the time that we are in our 90s, almost 50% of us will be suffering from dementia. Now, it's not inevitable. Not everybody will get demented. And there have been some well-documented cases of people who are well over 100 who showed no signs at all of dementia. But as we age, it certainly becomes more common. Alzheimer's disease would be the most common type of dementia. The second most common type of dementia is probably vascular dementia. One thing that many people don't fully appreciate is that dementia syndromes are often terminal illnesses, meaning that the patient is going to die from the dementia itself eventually. Alzheimer's disease is a terminal illness. It is a condition that people will die from eventually if they don't succumb to some other cause. And it's also a condition that causes gradual decline in the patient's physical abilities. So you'll see difficulties with gait and ambulation, swallowing, speaking, carrying out activities of daily living, bowel and bladder function. So there are many physical abilities that decline or deteriorate during the course of a dementia illness. There are some types of dementia that don't progress, however. An example would be traumatic brain injury. Once the patient starts to recover from the traumatic brain injury, they may see some improvement in their abilities, but then it usually plateaus at some point, and then from that point on, typically doesn't get better or worse. The same thing is true with alcoholic dementia, something that we see commonly here in our facility. We'll see residents who have been drinking excessively much of their life, and then later in life start to experience some cognitive decline. But when they get into this setting, a more controlled setting, and they're no longer able to drink, then we often see some improvement in the cognition, but it does eventually then level off, and that's typically where they stay until something else happens. And that something else could be Alzheimer's or some other form of dementia that occurs later in life and is kind of a separate process. The other thing that many people don't realize about dementia syndromes is that many of these patients have severe behavior disturbances and psychiatric symptoms. In fact, you can see virtually any psychiatric symptom during the course of an illness such as Alzheimer's disease. You can see hallucinations, delusions, mania, depression, anxiety, personality changes, just about anything you can imagine. In our facility, we try to focus on non-pharmacologic interventions first when we're dealing with those behaviors and those psychiatric symptoms. So we try to change our approach, we try to change the environment, we look at everything that we're doing to see if we can identify any triggers that could be eliminated. But if that is ultimately not successful, then we may need to consider psychiatric medication. The use of psychiatric medications in long-term care facilities is very heavily regulated, and it's monitored very closely. Next, I'd like to talk about delirium. This is temporary confusion due to some sort of underlying medical cause. Now, some of these medical etiologies for delirium are illnesses that seem relatively benign. So it could be something as simple as a urinary tract infection, a case of bronchitis. You could see delirium from a change in medication, from dehydration, There are many things that can cause delirium, especially in an older person or a person who already has or who is already in a compromised state neurologically. The classic presentation for delirium is acute, meaning it comes on very quickly. It's not a gradual change like you see in dementia. So the patient can be suddenly very different than they were even a day ago or even an hour ago. And they can fluctuate quite a bit. So throughout the course of the day, they might look quite different depending on when you approach them. They might be very confused in the morning, and by lunch, they can be completely lucid and having a conversation with you. And by late afternoon, very confused or agitated again. Patients who are delirious can appear subdued or agitated. And when they're agitated, they can sometimes be violent. They can have hallucinations. They can be very, very disturbed. We generally try to avoid using psychiatric medications to treat people who have delirium or related symptoms. The main focus in patients who have delirium is to address the underlying cause and then try to resolve that underlying medical problem. The next category would be personality disorders, and this is a group of disorders which can be very, very challenging for any nursing home employee to cope with or to manage. In order to meet criteria for a true personality disorder, these difficulties need to be lifelong. People typically are not diagnosed with a personality disorder at age 65. Usually what you'll see is, starting in early adulthood, a pattern of interpersonal difficulties. So these are people who may have burned all their bridges with friends and family. There may not be very many people around who want to be involved with them. That would be a clue, certainly, that the person may have a personality disorder. Now, somebody who comes into your facility and is kind of grouchy or difficult, you can't necessarily just brand them as having a personality disorder unless you know that person's background, because that could just simply be an adjustment difficulty. You know, a lot of people who move to nursing homes are very unhappy about it, and that person may have been someone who had a great personality right up until the moment that they were forced to move into a nursing home, and that may have turned them into someone who is a lot more difficult to interact with. There are many different types of personality disorders, and they're sort of separated into three clusters, A, B, and C. Cluster A would be some of the sort of bizarre or odd personalities, paranoid personality, schizoid personality. Schizoids are people who prefer to be alone. They don't really want to interact with others. They may be a little hostile toward other people and sort of into their own little world, doing what they want to do. Schizotypals are a little bit similar, but I would probably describe a schizotypal as someone who almost has a very mild case of schizophrenia. They may have some peculiar ideas. They may have some difficulties interacting with people and so on. Cluster B, which my mnemonic during medical school was B is for bad. Cluster B personalities are very challenging, to say the least. So borderline personality is one of the more severe types of personality disorder. In these patients, you see very extreme responses, especially when they're under stress. If they're being challenged or stressed somehow, they may overreact. But they can overreact to more favorable situations too. So one moment they can be on top of the world, feeling great about everything, and next moment everything is terrible. So now you may be thinking, well, that sounds a little bit like bipolar disorder, manic and depressive. In reality, I think a lot of these patients do get misdiagnosed as being bipolar for that very reason. But in my experience, borderlines are more reactive, whereas bipolars may shift moods for no apparent reason sometimes. Borderlines also tend to be fairly manipulative. They may sort of pit one person against the other. So this might be the person who, you know, you're working with one night, and she says, well, you know, so-and-so worked last night, and she's just terrible. She's no good. She doesn't know what she's doing. You're much better. And by the way, she said that you're really bad at what you do too. So they may try to pit you against your colleagues, and then they can shift. The same person who tells you one night that you're the best and the other one's terrible, the next night she may tell you that you're terrible and the other one's great. So you have to be aware of their ability to create splits within the staff and to cause chaos in that way. And I think when staff members are arguing amongst themselves over a resident's behavior, I'm always suspicious that there could be a borderline personality involved. Narcissistic personality disorder is also in cluster B. Histrionic would be the patients who are sort of the drama queens and drama kings, the people who want to be the center of attention, and everything is a big deal to them. So I think you probably have seen those tendencies at times too. Antisocial, it's sort of another word for sociopathic personality. So these would be people they break the rules, they break the law, they may have a legal history, they don't seem to be concerned about hurting other people, they may tell lies, they may be violent or threatening. So prisons are full of antisocial personalities. And then cluster C, these are the people who tend to be anxious and sort of insecure and so on. You've got the dependent personality. These are people who are very uncomfortable being by themselves or on their own, and so they may be on the call light quite a bit. They may be seeking your attention, wanting you nearby. Then you have the avoidant personality. These are people who don't really want to put themselves out there because they are fearful that they're going to be humiliated or rejected. So unlike the schizoid personality, the schizoid doesn't want any contact with people. The avoidant person wants contact, but they're just afraid that they're going to fail. And then there's the obsessive compulsive personality. So this is a case of people who tend to be very rigid. Everything must be a certain way. They don't like to work with other people unless they can be in charge. Everything must be orderly. And again, I think you can probably recognize that in some of your residents and maybe in your coworkers too. So that brings me to another issue, which is as you've heard about these illnesses or these conditions, and as you've heard me describe them, I'm sure a lot of you are thinking, well, that could be me. I have some of those features, or family members I know have them, or coworkers I know. The fact is, many of us have these personality attributes, especially at different points in time. If we're under stress or if we're in difficult situations, some of these things can come out. But in order for this to be a disorder, it has to be something that is persistent and interfering with our ability to function, interfering with our jobs, with our marriages, with our schooling, with our relationships. The other thing I want to say is many of these personality disorders don't fit into one neat category, into one neat disorder. A lot of them are personality disorders that may have more than one of these attributes, and there may be a mix of traits. So how do we treat personality disorders? Well, that is complicated. Counseling can be beneficial for treating personality disorders, but only if the client or the patient, the resident, wants to change, only if they really see a problem and they want to improve their ability to interact with people and to get along with people. So unfortunately, a lot of people who have personality disorders don't really realize that they have personality disorders, and they aren't very motivated to make any changes. Sometimes I think counseling can be presented to them as a way for them to cope with some of the difficulties that they're encountering in their life. But at the end of the day, they may not accept counseling. So then what do you do? What do you do if you have a person who has a severe personality disorder and lives in your facility? Then it may come down to behavior management, like getting your team on the same page, and approaching that person in a consistent manner. And we're going to talk more about that in a few minutes. Next, I want to say a few things about substance use. In our facility, we certainly have a number of residents who have a history of alcohol abuse. And we're very, very careful about alcohol use during the time that they reside in our facility. They have to have a doctor's order in order to use alcohol, even on a recreational outing and going out for dinner and so on. The reason for that is that the acute effects of alcohol can be very detrimental in many ways. It can increase mood depression, it can cause gait instability and lead to falls, it can cause medication interactions. There are a number of things that we need to be mindful of. And then the chronic effects. Now, when we talked earlier about alcoholic dementia, and also known in some cases as Korsakoff's syndrome. So when people drink for many, many years, for some people that has a cumulative effect, and not only on their cognition, but they can have neuropathy, which would be pain in their extremities sometimes. They can have liver disease, gastrointestinal problems, a variety of medical problems from chronic use. And all of these things we often have to manage in long-term care settings. As we look forward, the baby boomer generation, we think, is more likely to use illicit drugs like marijuana. And I guess marijuana is not really illicit in some places now, and in the future it may not be illicit at all. And that will probably be a unique challenge in long-term care as well. We are also seeing an uptick in prescription drug misuse, including opioids and benzodiazepines. When you review medical records of your residents, you may in some cases see the term unspecified blank disorder used. For example, unspecified depressive disorder, unspecified anxiety disorder, unspecified psychotic disorder. What this means is the resident has symptoms in that area, but not enough information is available to meet DSM criteria for a specific disorder. So you've got a patient, for example, who may look very depressed, but that person may not be able to communicate with you very well. They may not be able to talk about their appetite or their sleep patterns or their energy level and so on. And you may not know them well enough to have any observational information about that resident. So in some cases, we will use unspecified blank disorder as kind of a preliminary diagnosis until we have more information. Now I'd like to shift gears a little bit and talk about decision-making capacity. A lot of times you'll hear the term competency used, and it's not always used in the right context. Competency is a legal term. Competency is determined by a judge at a hearing, usually a guardianship or conservatorship hearing or a criminal hearing. Decision-making capacity is a clinical determination, usually made by a nursing home resident's primary care provider. In a lot of facilities, they will break this down into personal decisions, like healthcare decisions, as well as financial decisions. One important thing to realize about decision-making capacity is that it can change at different points in time. So for example, if you had a person with bipolar disorder who was manic and psychotic, they very clearly might not have decision-making capacity at that time. But if they get on the proper medication regimen, they could stabilize and then regain decision-making capacity later. Now, there are some situations where decision-making capacity obviously is not going to fluctuate. For example, someone who had Alzheimer's disease, the course of that illness is going to be very clear. That person is going to get worse and worse in terms of their cognition and their mental status, so they would not regain decision-making capacity at any point. In some cases, the primary care provider may enlist the support of a mental health provider in making that determination. They may ask for neuropsychological testing or other forms of assessment from a mental health clinician. There are a number of legal issues that we should consider as well. Some people in nursing homes or in long-term care facilities are on civil commitments. The thing to remember here is that civil commitment does not necessarily involve decision-making capacity. In most states, like Iowa, a commitment is issued because the person has a serious mental impairment and because of that is a danger to self or others. So in Iowa, for example, it simply means that the person has to live at the facility and has to accept mental health treatment. Beyond that, it has no impact at all on other medical or financial decisions. In some cases, a nursing home resident may be assigned a guardian or a conservator by the court. In this case, the judge or magistrate has determined that the person is incompetent and unable to make personal decisions and needs a guardian, or unable to make financial decisions and needs a conservator. Typically, in the case of a guardianship, it's important to be very specific about what the guardianship covers. So it may need to be very specific about code status, about determining where the person would live, anything that could potentially come up, any decision. But if all of that is put into the guardianship, it can potentially be quite powerful. It can give a person the same power that a parent might have over a child, for example. Durable power of attorney is a document that many of us will sign during a period in our life when we do have full decisional capacity. And what we do then is, on a legal form, we determine who would make decisions for us should we ever lose our decisional or decision-making capacity. Once this has been accomplished, and once the person has been determined by their primary care provider to no longer have decisional capacity, then that person who is designated is firmly in control of those decisions. General power of attorney, on the other hand, is not quite as durable. This is something that can be assigned and then revoked quite easily by a resident or by anyone, and it simply empowers somebody else in their life to manage some of their affairs. So, for example, it's very common that a nursing home resident may say, I want my son to have general power of attorney so that he can manage my bank account or pay off my bills or help me sell my house, those kind of things. And as I mentioned, it can be revoked quite easily if the person wishes to do so. Okay, now we'll move into a different realm, and that is the management of challenging behaviors. So when you encounter a difficult behavior in a nursing home resident, in a long-term care resident, I'd like you to think about these questions. Is there any danger to the resident or others? Does the resident have decision-making capacity? So we're going to handle a situation quite differently depending on whether that resident has capacity. If a resident, for example, came up and grabbed the buttocks of a staff person and made a sexual comment, if that person had Alzheimer's disease and did not have decisional capacity, we would handle that quite differently than we would a resident who has full capacity and does not have a mental illness, obviously. So we always want to be thinking about that dimension of the situation. Does the resident have that decision-making capacity? Always be thinking, do you need to share this information with somebody else, with a supervisor or someone in a position of authority? And then, of course, have you documented, if you're in a job at the facility that involves documentation, have you documented this carefully? Let's talk about boundaries a little bit. I think this is very important in long-term care facilities. It's important, in my mind, for all employees to view that resident as a disabled person that we are paid to assist. But this is not as easy as it seems, because we're always trying to strike that balance between being warm and showing empathy, but yet maintaining some professional distance. When you spend all day, every day with nursing home residents, it's very easy to develop warm, friendly relationships with them, and we should. We want the environment to be therapeutic. We want it to be comfortable for that person. That's what we're paid to do, is create a welcoming environment. However, it is very important for us to maintain that distance, because if we start giving certain residents special treatment, it can affect our clinical judgment, and it can affect the perceptions of the resident and those around the resident. Those of you who have children, I'm sure, have realized that if you treat one of the kids a little better than the rest, it doesn't take long for the others to figure that out, and then they become resentful about it. And the same thing is true in long-term care facilities. If you come in and greet a certain resident every day and joke around with that person and compliment them, it's very possible that residents who are sitting on the side or in the periphery somewhere watching, it's very possible that they would feel like you have a preference for that person and you don't like them as well, and that they could feel sad or resentful about that. It can also affect your judgment because sometimes you can be in a position where things are not so good between you and the resident in question, and maybe you are reluctant to do some things that you need to do because you feel a friendship toward that person. It's very important to realize that the people we care for are not family members. This is not your mother or your father, your sister or your brother. Again, like I said earlier, it's a disabled person that we are paid to assist. And we want to make sure at the end of the day that we're treating that person appropriately and not getting too close. We need to be careful about our own self-disclosure, about telling people things about ourselves. And there are many reasons for this. One is that we don't want to spend a lot of time talking about ourselves. We're here for them. It's not our time. So it's not really appropriate for us to be discussing, the problem your son had or your divorce or, your mom's illness and so on. I know those are the things that make us human, but at the same time, you don't want to spend a lot of your professional time dealing with your own issues. Not only that, though, there are some situations where residents may be very friendly initially, and then things get a little worse later, and they may turn around and use some of that information against you in a hurtful way. If you have your boundaries intact, then it's easier to brush off those insults. If somebody makes a comment about your weight or your race or something like that, and it's coming from a person that has issues themselves, has mental health issues, it's much easier to brush that off and to rise above that if you have these boundaries intact. Next, I want to talk about basic communication skills. And I know some of you who are listening probably know some of these things already. I hope I'm not insulting your intelligence, but I think these are some good basic tips that a lot of nursing home employees could utilize, and I think that they would find these beneficial. First of all, I think it's important to be down at the eye level of the resident, like I've shown in the picture. A lot of times we can get busy and we can stand over people and talk because we don't really have a minute to sit down and talk with them at eye level. I think that's a mistake. I think we should always try to be down at their level. It's very reassuring. It promotes better communication. I once read somewhere that there is only one culture in this world where people are comfortable with having someone stand over you and talk to you while you sit, and that's in North Korea. So most cultures do value that eye-to-eye or face-to-face contact. Appropriate physical contact is important too. I'm very measured with my physical contact with my patients and residents. I like to shake hands. I enjoy that. And once in a while, I will pat people on the shoulder or even put my hand on a person's arm while I talk to them. Although I should say there's an added benefit with putting your hand on somebody's arm. If it's a dementia patient who is prone to be aggressive, that might help to prevent you from getting suddenly smacked in the face too. Hugging is a little more dicey, I think. Again, it goes back to what we said before. We don't want to be too cold and too distant, but we need to strike that balance. In some cases, especially if you've got a male resident and a female employee who's younger, contact like hugging can be misinterpreted, and it can lead to confusion or problems in that working relationship. Always make sure that the resident can hear you, and I know that should go without saying, but some residents have become very good at acknowledging what you say, even though they can't really hear you. They'll shake their head and smile and so on, and it's very important that you stop once in a while to say, "Can you hear me okay?" Just try somehow to get them to acknowledge what you've said if you have any doubt at all that they didn't understand it. I think maintaining an appropriate pace is important. A lot of us live in a world that's very busy. We're doing a lot of different things. We've got a lot of balls in the air. And so sometimes we're thinking and talking at a very rapid pace. As we get older, the speed of our thought processes slows somewhat. And certainly there are some elders who have very sharp minds and can process information very rapidly, but there are many others who really need us to slow down a little bit. I think it's important to address people by whatever name they prefer and by whatever pronoun they prefer, and then stay completely engaged. And I think this is really difficult in our society right now. Like I said earlier, we're all busy. We have a lot of things going. And what you don't want to do, though, is when you're interacting with a resident, when you're talking with a resident, you don't want to look around the room. You don't want to look at your watch, at your phone. You want to stay in the moment with them, 100%. That is so important. When you look around the room, what that signals to a person, even a person who has dementia, is that your mind is someplace else. You've got something more important you want to do or need to do, and it's definitely a barrier to good communication. I want to talk a little bit about active listening. I love the expression, seek first to understand, then to be understood. I think there are so many situations in life where that is important, and certainly in long-term care, it's very important. After someone has told you something, if you can restate it back, summarize it back, and so on, reflect it, then it's a good way to signal to the person that you've heard what they've said. So if the person comes in and says, my meal was served cold tonight, you can restate that back. So what I'm hearing you say is that the meal that was served last night was cold. Occasional encouragers or cues, just simple things like or nodding your head, just a way to acknowledge that you're with them, that you're listening. Labeling emotions. So in the case of getting your food served cold, if the person said they were very angry about that, you could, again, when you're restating that, you could label the emotion and say, well, so you got the meal served to you cold and you felt really angry about that. And that was really upsetting for you. And you want to label the emotions in a way that doesn't make them feel like you're talking down to them or accusing them of any overreaction or anything. Clarification. Sometimes people are sort of disorganized or they aren't very focused, and you just need to go back and clarify what you just heard or what they were trying to say. Validation. Validation is very important. And validation doesn't mean that we simply agree with a person. It just means that we validate their feelings. So for example, if the person's talking about getting their meal served late and cold, and then it made them angry, a validation would be, well, you know what? If I was served a meal that I thought was cold, and if I thought it was served late, I would be mad too. So it's not to say that you're agreeing that the person who served the meal is a bad person. It doesn't mean that you're assuming that the meal was cold or late, because you don't really know that for sure. You just know the person thought it was. So again, just to go back and say, if I was in your shoes, if that was my perception, I'd feel the same way. And that validation does really help. Sometimes people get very overwhelmed, and sometimes you just need to take a break for a few seconds. Just pause or a moment of silence. It gives people a chance to recoup their feelings and just to take a breather, take a deep breath. And again, in our hectic society, a lot of times people don't tolerate silence very well. They feel like every moment has to be filled, but it doesn't. Some people get off onto a rant, and they can go off on a tangent, and they need to be redirected. And one way of doing that is simply to say, well, I think what you're talking about is important, and maybe we can come back to that sometime, but I need to go back to my original question because I still don't understand completely what happened. So again, if you just sort of imply that the tangent that they went off on is something that you may come back to later that you're not dismissing, that's a better way than to get back to the original question or matter that you need to clear up. And then explore consequences. So some people, some long-term care residents, for example, might make threats to say, well, I'm leaving. I'm just walking out of here and walking down the street. Well, then, again, just exploring the consequences. Well, what would happen then? Well, it's pretty cold out. Do you think you would be affected by the weather? Where would you go? How would you get your medication? And so on. Here are a few roadblocks to good communication. Sometimes interrogating people or digging too much. Why'd you do that? Why this? Why that? That can be problematic. Don't be too quick just to give superficial reassurance. Just a quick pat on the back and saying, oh, it's all fine. No, it's good. No worries. It'll all work out. That's not always helpful because it makes people feel like you're just kind of brushing them off and you're not really willing to listen to what they have to say or really dig deep on the problem. Advice is not always helpful, and that's different from problem solving. But giving advice just to say, well, when I went through this, this is what I found helpful, or this is what my mom did when she went through it, it's not always the most helpful thing. Patronizing, of course, none of us like to be patronized. And I think a lot of us don't mean to be patronizing, but it can happen, especially with a nursing home resident who is functioning at a low level. Preaching, none of us want to be preached to unless we're in church, of course, right? And then interrupting. Somebody once said that when you interrupt somebody, what it really means is that you feel that your thoughts are more important than their thoughts. So it also means that you don't really want to hear what they have to say. You just want them to hear what you think. And that's sort of the opposite of what we said before. First seek to understand, then be understood. Okay, now I want to say a few things about just sort of the general approach to behavior problems in long-term care. When I first started in psychiatry, a mentor of mine was famous for saying, don't just do something, stand there. And what she meant by that is mental health is a little bit different than other fields of medicine. A lot of medical professionals are taught to spring into action and solve problems. And in mental health, a lot of times, if at all possible, it's best just to take a step back and let things simmer a little bit. Just look at the situation carefully before you react. And I think it's important to check yourself. Are you feeling anxious? Are you feeling angry? What's going on inside of you? What's your facial expression like? What's your tone like? What are your gestures? And the picture I put up on the slide is sort of the opposite of what I would normally expect from a medical professional who is dealing with a resident issue or a resident behavior. I think it's important to offer residents options instead of saying no. So, for example, if you have a resident who says, oh, I'm going to break a window or I'm going to break that door down if I don't get a beer. Well, we don't want to say, no, you can't have a beer. We don't serve beer here in the memory care unit. Instead, you would say, well, we have some coffee or some juice. Would you like that? So again, I think a lot of you are aware of that basic principle, but I want to put it out there in case you aren't. Reinforcement is a very important principle. And I have always believed as a mental health professional that behavior is changed much more by positive reinforcement than it is by punishment. And the reason for that is that positive reinforcement really changes the way that we think, and a lot of times on a level that we aren't even aware of. When we get rewarded after a certain behavior, it stimulates the reward center of our brain, and either consciously or subconsciously, we feel like we want to do that again. So if we pleased someone and that someone rewarded us, then naturally we want to please them again. Punishment, on the other hand, is simply intended to harm someone or make someone uncomfortable in response to something they've done. And all that does is ensure that the person doesn't do whatever the behavior is in front of the punisher, or doesn't do it in a manner which might lead to them getting caught. So it just leads to avoidance more than anything else, and not really a change in the way that a person thinks. Now, having said that, there is some difference between natural consequences and punishment. If you've talked to someone many times about a bad behavior and you've informed them that the consequence might be such and such, and then later they do actually end up experiencing that consequence, that's quite different than a punishment where you simply inflict an uncomfortable or punitive measure against a person after they've done something that you don't like. For example, if a resident made a derogatory statement about the weight or appearance of a nurse, and that nurse immediately responded by saying, "That's inappropriate. Just for that, you're not going on the rec trip tonight." Well, that would be a punishment because it's an attempt by the nurse to strike back at the person and inflict discomfort upon that person in retaliation for something that he did. On the other hand, though, if you have a resident who makes inappropriate and insulting comments to staff and residents, and every time he goes on a recreation trip, he ends up disrupting the trip by insulting people in restaurants or out in the community or other residents who then are made to feel uncomfortable, it's very possible that an administrator might have to talk to that person and say, "Look, if you keep doing this, you aren't going to be able to go on a trip anymore. We can't allow this to happen. It's causing discomfort for other residents, and they don't enjoy the trip as much when you do that." So if the person persisted in doing that after they were talked to about it, I would consider that a natural consequence of their behavior and not necessarily a punishment. So there is a fine line there, but I think it's important to keep that in mind. And in long-term care settings, we would never want to be viewed as punitive toward a resident. That would not be appropriate under any circumstances. Praise and encouragement can be very powerful reinforcements or modifiers of behavior, and it's important to catch people being good. So for example, if you had a resident who had schizophrenia and never took a shower, and then suddenly one day just randomly decided to take a shower and get cleaned up, you'd want to make sure you really praise that person, give them a lot of positive reinforcement. You know, statements like, "Jim, man, you look good. You clean up well. Oh, you should do that more often. You look so good." Even little statements like that can be important. They can really modify behavior. And also don't forget that sometimes behaviors like scolding or disgust can actually be reinforcers themselves or be rewarding for some people. As an example, if you had a male resident who called a staff member to come in and help him in his room, and he sat on his bed and masturbated in front of her, if she got very disgusted and said, "Well, that's inappropriate, that's really gross, you should stop doing that," and got an angry look on her face and walked out of the room quickly, the resident might be reinforced by that. He might feel like, "Wow, did you see the reaction I got out of her? That was funny," or "That was fun. I really pushed her buttons." So again, we're going to talk more in a minute about how to manage sexually inappropriate behavior. And I think one of the important concepts that we'll talk about is not overreacting when those behaviors occur. Limit setting is important, but only for people who have decision-making capacity. Setting limits on people who have dementia or severe mental illness who don't really have decisional capacity can be very futile. Once we set limits on a person, and usually what we're talking about are people who have personality disorders, for example, who break rules frequently, and it may become necessary for us to put limits on that person. But before we do that, we need to confer with the entire treatment team and not just simply threaten the person with consequences. So everyone must be on the same page. And I would liken this to a situation where kids may bounce around to different households like grandma's house, mom's house, dad's house. If those households aren't all on the same page, it doesn't take that kid very long at all to figure out who the weak link is and focus on that person. And by the same token, if you're going to put consequences out there and set limits, then everybody on the team, every shift, needs to be on that page. And that may even include other non-clinical employees, like even housekeepers, maintenance. There may be a lot of people who need to be informed about those limits and to be all consistent, with the rest of the team. There may be some situations where you need administrative action. There may even be situations where a person is notified that if they continue a certain behavior, it could lead to discharge. And there may even be situations where the police need to be called. People who live in nursing homes or other long-term care facilities are not above the law. If they break the law and they have full decision-making capacity, then it may be necessary for the police to come out and give that person a citation or even arrest that person. In some cases, I have found it beneficial to have a uniformed police officer come out and talk with a resident about a behavior if we felt like that behavior was criminal. And even if we did not proceed with filing any charges, just simply having a uniformed police officer come out and explain what the law is to that person can be very beneficial. I want to talk a little bit about dementia behavior. So in general, when you're seeing behavior disturbances in people who have dementia, the key thing is to soothe that person and distract the person. It's not at all helpful to argue with that person or try to correct that person. And like we said earlier, be aware of your nonverbal communication, your tone, your gestures, your facial expression. You want to try to approach people who have dementia head on. Don't come in from the side. Don't make any abrupt moves. And it's important to get to know the resident and be creative. So, for example, I once had a resident who was very, very involved in Western culture. Cowboy hats, cowboy boots, movies about cowboys, so on and so forth. And anytime that he would get angry or upset, if someone would just engage him in a conversation about Roy Rogers or Gunsmoke or something, it was very de-escalating for him, very soothing, and also a distraction. I want to talk about disorientation, delusions, and disorganization, 3 D words. And at first glance, it may seem that these are all very similar, but there are some important differences. Disorientation is simply confusion about the time, place, or someone's identity. And in some cases, we can gently reorient people. So if a person said, well, I've got to get outside and plow the field, it's going to be too late, I need to get out there, and the person lives on a memory care unit, you might be able to reorient the person and say, hey, Jim, you don't farm anymore, you retired, you don't have to go out now. Now, having said that, some people are so confused that it may be futile to reorient them. They may understand that in the moment, but they may not retain that information. Delusions, on the other hand, are false beliefs that are very strongly held in spite of evidence to the contrary. So when you encounter a person who has delusions and you realize that those delusions are fixed, and what I mean by fixed is that there is no doubt in their mind that this is true, that this is reality for them. If delusions are fixed, then we don't want to challenge or correct the person. We don't want to debate with them, but we don't want to agree with the delusions either. It's also important to validate the person's feelings about the delusions, although not the beliefs themselves. So, for example, if I encountered a schizophrenic patient who believed that there were aliens in orbit controlling his movements, how I might approach that is to say, well, Jim, I don't really know much about aliens and so on, but if I thought there was somebody up in a spaceship controlling my movements, I'd be upset too. That sounds like a really uncomfortable feeling. Is there anything I can do to help with that? So again, just validating that, well, if this was in fact happening to me or to anyone, it would be normal to be upset about it. But the big thing is if. You don't want to leave them with the impression that you believe in, the delusional thought that they have. Sometimes it's also helpful just to emphasize safety and security. This is particularly helpful in cases where people have paranoid delusions. I've seen a lot of nursing home residents who think that someone's going to come and pick them up and take them away. The police, criminals, etc. And what I tell them is we have staff here 24/7. They keep an eye on everything. Everybody here is safe. By doing this, we can simply reinforce that the person is safe and secure without getting into any kind of discussion about whether their paranoid belief system is viable or reasonable. Thought disorganization can occur in a number of disorders, but we typically see it most, I think, in schizophrenics or in people who have dementia. In severe cases of schizophrenia, you can see people who have very nonsensical, bizarre, inappropriate types of thoughts. They can express these thoughts in a very abrupt nature. It's possible that you could have someone who just, suddenly blurts out something very inappropriate or even sort of menacing. And the key thing is that we should not overreact. We shouldn't correct the person. Again, I think it's important to, don't just do something, stand there and just take it in, listen carefully, and then offer assistance if appropriate. So if someone walks up to you suddenly and says something like, "I know you raped the devil," and they have an angry look on their face, I think it's better just to let that simmer for a few seconds and just say, "Well, Jim, you look like you're having a rough day. Is there anything I can do to help?" Some people who have thought disorganization may also try to communicate meaningful words or phrases amongst all the gibberish. So, for example, you may have a person come up who says, "Well, the desk and the speaker were brown, but my mom is sick right now, and the wall went over the moon. But then I drove the car, and I'm worried about her. So let's get an apple and then go out for a breakfast." So amongst all that, what you might take away from that is, "Oh, Jim, I didn't know your mom was sick. I'm sorry to hear that. I hope she gets better." Sexually inappropriate behavior can be very distressful and disruptive in a long-term care facility. But I think we have to look at the context in which the behavior occurs. Is the resident confused? Is he simply lonely? Or is he trying to be intimidating? And I say he because most of these behaviors do occur with male residents, although occasionally you can see it in a female resident as well. In my experience, the few cases I've seen of females who were sexually inappropriate occurred within the context of mania, which is pretty easy to treat with medication. When sexually inappropriate behavior occurs, I think it is important to inform the person that it's not appropriate, but like we said earlier, don't overreact. Don't react too strongly. I always advise staff members to be almost robotic in the way they respond. You don't want to have a pleasant look on your face, nor do you want to have an angry or offended look. Just a very flat expression. Inform them very clearly that that's not appropriate, and then get out of the situation if you can, because your presence in the situation, like I said before, could be reinforcing. Now, there are some situations, like if you're doing cares, where obviously you can't necessarily step out, but if you're able to leave the situation, that does sort of put the person in timeout, so to speak, and reduce some of the stimulation that might be reinforcing the behavior. Sometimes you see people who are just very lonely. Let's face it, there aren't very many sexual outlets in a nursing home, and older people still sometimes need sexual outlets, and they may reach out to staff members, especially if you've got an older male resident living in a facility that's staffed primarily by younger female employees. And I think when this occurs, it's important to communicate to the person that it's not appropriate, but we also don't want that person necessarily to feel shame or guilt. We want them to feel like, okay, we can move forward, we can still work together as long as you understand, where the boundaries are. It could be argued that anyone who works in a nursing home has some sort of power over that resident, over their life. And in that context, it really would be inappropriate. Of course, any time that sexually inappropriate behavior occurs, it's very important to keep supervisors and administrators informed. There is quite a bit of grief in long-term care settings. And many of you, I'm sure, know the classic stages of grief. What we need to keep in mind, though, is not everybody goes through those stages in that order. Sometimes they may jump around. They may stay in one stage for a long period of time. Everybody grieves a little bit differently. Keep in mind that people are suffering from grief related to many different types of losses. It could be a loss of physical functioning, a loss of their home, of their independence. They may have lost a spouse recently. They may not be able to drive anymore. So it's very common, especially when people first move in, that they're grieving these losses. And it's not just about the nursing home itself. They may project that onto the nursing home, and they may complain that they hate this place and that it's an awful place and so on. But what really may be happening is they are simply grieving all the things that they've lost. As we said earlier, it's good to offer assistance, but advice is not always that helpful. One thing that I think is very helpful for anyone who is grieving or depressed is a life review or reminiscence. So, for example, Jim, I heard that you used to work at John Deere. How many years did you work there? Oh, about 25 years. What was your best memory of working at John Deere? Well, I got that award once. Oh, an award? That sounds great. Tell me about that. Or you could say, Mabel, I heard that you were married for 64 years. Oh my goodness, that's a long time. What was the most fun you ever had with your husband? What was the best trip you ever took? Something like that. This is beneficial for many nursing home residents, even those who have cognitive difficulties and memory deficits, because in many cases, people who have dementia can't remember more recent events, but they still have good recollection of past events. Thoughts of self-harm can occur in long-term care settings, but these situations need to be taken within the proper context. Some residents may have urges to injure themselves, but they may not have suicidal thoughts. So, for example, there are some folks who have the urge to cut or to burn, but they have no intent at all of taking their lives. There are some people who simply have fantasies of death, like, oh, what would it be like if I died tomorrow? Would I be better off? Not everyone who wants to die is depressed. There are some people who have what I would call a rational desire to die. So I'm certainly not endorsing euthanasia or anything of that sort. But what I'm saying is we shouldn't necessarily react to every single situation as if it was a case of depression or mental illness. For example, if you had a 95-year-old resident who was in chronic pain every day, unable to use the toilet, unable to bathe, had to be fed, was confused, had no family left, if they said that they were ready to pass on, would that necessarily be a case of depression or mental illness? Probably not. Some people have fleeting suicidal thoughts that may be sort of on again, off again, but there are of course, some people who can have very persistent suicide thoughts. And that becomes obviously much more concerning. So at that point, I think a safety assessment is important. We need to ascertain whether they have a plan and whether that plan is viable. Do they have the means to carry it out? And do they have the intent to carry it out? So, for example, if we had a nursing home resident on a memory care unit that was secured who said, yeah, I'm going to blow my brains out with a shotgun. Well, we know that person is not going to gain access to a shotgun. But if that person said, I'm going to break a window and and cut my wrist on the glass, well, that's serious. Or if they said, I'm going to wrap a cord around my neck, that could be serious. So we have to take that into consideration. And by intent, I simply mean, are they determined to do it or not? And sometimes you can ascertain that by what are their reasons to live. Some people would say, well, I'll never do it because I don't want to harm my family, or it goes against my religion, it would be a sin. And those are very reassuring things. But if you have a person who says, I'm going to do it, and they don't really have any reason not to do it, oh, that's obviously very, very concerning. Another thing that really correlates, I think, with danger is hopelessness. If a person sees no hope at all for their future, that makes me more concerned for their safety. Occasionally, nursing home residents will make threats of violence. And again, we have to take this within the proper context. If it's on a dementia unit, we're going to manage that very differently than we would in a situation where we have a person with full decisional capacity who's making threats. De-escalation is very important. Sometimes it's just simply a matter of talking to that person calmly and using some of those tips we mentioned earlier. Always be mindful of your environment. Make sure you have a route for escape. If you're going to go in and talk to somebody who's making threats, make sure you're closer to the door than they are. And don't be too overconfident. Even people who are very, very old and very small can sometimes do a lot of damage. At the end of the day, it's very, very difficult to predict violence or suicide. Even people who are experts in the field would say that they aren't always right about predicting whether someone might hurt themselves or others. However, one of the best predictors of future behavior is past behavior. So it's always important that you know whether that person has any history of attempting suicide or of violent behavior in the past. We have a lot of different options for managing unsafe behavior, and by that I mean behavior that could be a danger to self or others. We can step up monitoring. We can check on a person more frequently, sometimes even put them on one-to-one observation. Sometimes we can restrict them within the facility, ask them to stay in the building or stay on the grounds and so on. Sometimes non-pharmacologic interventions like offering comfort measures can be beneficial, a warm blanket, a cool drink, something like that. Occasionally, it's a matter of changing medication, offering PRN medication to someone who's very anxious. But of course, in some cases, in more acute cases, we may have to actually call 911 and have the person transferred out. When we transfer people out, typically they will go to the nearest emergency room or emergency department. Medical clearance would be the first priority, and that usually comes in the form of a brief exam by a medical professional and then lab work. And the purpose of the lab work is to rule out any acute illness that could be causing mental status changes. Once that's been ruled out, then usually they will have some sort of mental health professional evaluate the person. That can occur by telemedicine or in person. And if they feel then that the resident needs to be admitted to a mental health unit, they would have to determine whether that person is willing or able to go voluntarily or whether they would need a court order or commitment in order to go. Usually they would be transported to a mental health facility by law enforcement or by ambulance. And a typical length of stay in a mental health facility, in a psychiatric acute care facility, would be about 1 or 2 weeks. Thank you very much for your attention, and I wish you all well.